Hello, my name is Arne Bleijenberg. I'm a PhD student in the Amsterdam University Medical Centers in Amsterdam, and I'm here together with my supervisor.
Hello, my name is Evelien Dekker. I'm working in the same hospital. I'm a professor in GI oncology and an endoscopist.
Yeah, and the journal Gastrointestinal Endoscopy has allowed us the opportunity to elaborate some more on an article that was recently published by our group in this journal. And this article was titled "The Long-Term Outcomes and Natural Disease Course of Serrated Polyposis Syndrome Over 10 Years of Prospective Follow-up in a Specialized Center." And Evelien, maybe you want to start with telling why we think this study is worthwhile reading.
Yes, well, I think it's a special study, for me at least it is, because it covers the work of 4 PhD fellows starting before 2010 even, and covering all their work. So we followed a cohort that by time grew of patients with serrated polyposis syndrome. Actually, at the first time we started, the syndrome was still called hyperplastic polyposis syndrome, and we have followed this cohort for during all the years. We have done that in our dedicated outpatient clinic. We have an outpatient clinic for high-risk patients for colorectal cancer with familial syndromes like FAP, MAP, Lynch syndrome, but also now serrated polyposis syndromes, and we get many patients referred from all around our country.
Yeah. So, and since we have such long-term follow-up available, that gave us the opportunity to answer some interesting hypotheses. So one of the most important hypotheses that led us to set up this cohort study was that we in this outpatient clinic we actually observed, not supported with data, just our own observations, that patients after they had been cleared from their initial polyp burden had fading out polyp burden. So after a couple of consecutive surveillance colonoscopies, we had the feeling that we were detecting less and less and less polyps until eventually people did not have so many polyps at all. And to back up this hypothesis, we had the theory that right after a patient is cleared from its initial polyp burden, the first subsequent surveillance colonoscopy is the most likely one to detect polyps that were missed during the initial clearance. And as the patient undergoes more and more surveillance colonoscopies, the chance that there are still polyps left in situ from the original clearing phase becomes smaller. So this was the hypothesis that we had the opportunity to study in this cohort. But actually our data did not really show this hypothesis to be true.
No, actually that was indeed surprising to us. Again, this is really our feeling in daily practice, but again, in this cohort, not shown. However, I think there's still more work to do, and maybe we will find this effect in specific subgroups. Like, for example, there's patients that have serrated polyposis syndrome related to their smoking behavior, and some of them quit. And we definitely have the feeling that those patients have a reducing polyp burden by time. Like one of our patients, she came to our unit at age 25, I think, heavy smoker, and she had a huge polyp burden that at that time we thought was undoable to clear endoscopically. We discussed surgery with her. Actually, she even went to the surgeon, but came back and she said, well, I don't like the surgeon so much, I like you better, so why don't you just try? I'm happy to come back many times for my polyps to be cleared. So we started, and we did. And since then we are following her, and actually she knows all my PhD fellows because she's seen them all in the outpatient clinic, updating her about our research, but she still has her colon in, and so maybe she's one of the examples of someone who quitted smoking with a good effect. But yes, to come back to the first question, maybe there is subgroups where indeed this is true, so we need to have more follow-up of the patients, I would say.
Yeah, and also this would require quite large studies, because in our study, unfortunately, we did not have enough statistical power to separate the smokers from the the current smokers from the ex-smokers, because that would be a very interesting comparison for future studies. Now, another finding in this study was quite reassuring and was actually quite in line with other previous prospective cohort studies of SPS patients, and that was the remarkably low incidence of colorectal cancer. So in our cohort, we found a 5-year cumulative incidence of 1.3%, and that's much lower than if you look at really old cohort studies reporting up to 7 or 8% 5-year cumulative incidence rates. And to us, this told us a couple of things, but most importantly, that the current approach in managing serrated polyposis syndrome is quite effective and actually works. And one of the most important pillars of this management is that a patient is now, and has been over the past 5 to 10 years, first cleared of its initial polyp burden, so all the relevant polyps are taken out, and only then will a patient enter the surveillance phase. And this has turned out to be quite effective. But equally important, I think, is that over the past 10 years we have had a substantial increase in the quality of colonoscopy.
Yeah, so indeed, awareness of quality of colonoscopy as well as awareness of this syndrome and what those polyps look like probably has a dramatic effect on of the quality and the safety of keeping those patients with serrated polyposis syndrome under surveillance. So we do prep the patients nowadays quite well. We score the bowel prep with the Boston Bowel Prep score. If not good enough, patients are sent back in. We use high definition endoscopes, sometimes adding virtual chromoendoscopy like MBI or BLI, sometimes using traditional chromo might help. And again, we know what the polyps look like and we know what to look for. So yes, we've I think during the past 10 years, the way we survey our patients has dramatically increased. Because last but not least, I was telling about that previous patient that we sent to the surgeon to discuss subtotal colectomy with him. Nowadays, we would not send those patients to the surgeon. We tend to resect more and more polyps in those patients. Explaining them on beforehand, it will take maybe 3 or 4 clearing endoscopies before we get to a more resting phase, getting back to a 1 yearly or even once every 2 years colonoscopy. But we resect in some patients over 100 polyps, and if it's going well, the patient supports it well, he's motivated to do proper bowel prep at home. I think this is very well doable and safe.
Yeah, and I think once more it shows that we are now very much aware that we need to find every last relevant polyp before we send patients for surveillance. As a closing, I think it would be nice to discuss a little bit about the future, our opinion about the future of serrated polyposis syndrome management. Because as we said, the cancer incidence is actually quite low at this moment during surveillance. So we might be reaching the ceiling as to how far we can go with preventing cancer. But this prevention and this low incidence of cancer comes at a high cost of many colonoscopies. So patients are subjected to colonoscopies every 1 to 2 years. That's highly frequent. And we are convinced that if we can improve risk stratification in serrated polyposis syndrome, we will be able to further reduce the number of colonoscopies patients have to undergo without increasing their risk of cancer. So that's our hope for the future of serrated polyposis syndrome. Thanks for your attention, and if you have any questions remaining, please do not hesitate to let us know. We would be happy to respond.
Definitely. Bye-bye from Amsterdam.
Bye-bye.